Hello, I'm Doug Musio. This is City Talk. On March 23, 2010, President Obama signed the Patient Protection and Affordable Care Act into law. It is the most sweeping healthcare changes in nearly a half century. I'm confused, very confused. I bet you are too. What will the changes do? What won't they do? Why all the conflict? Why all the confusion? With me to dispel part of the confusion is Shoshanna Sofer, a colleague of mine at the School of Public Affairs at Baruch College. Shoshanna holds the Robert Luciano Chair of Healthcare Policy at Baruch. She is an internationally recognized expert in healthcare measurement and improvement, in the development of materials and interventions for healthcare consumers, and in the assessment of medical education programs. Professor Sofer has been named the Lorraine and Ralph Lubin Distinguished Visiting Professor at the Weill Cornell Medical College. Welcome back, Shoshanna. Help! Help! Why am I so confused, or why is it so confusing?
Well, first of all, it's huge. Okay, we've got a law that is in congressional printing, over 2,000 pages long, which, if we boiled it down to normal printing, would be 1,000 pages
So
long.
it's a monster.
It's got 11 titles.
I know, I read them.
And it's also, I think what we got to be recognizing is that people on Capitol Hill and in the healthcare policy world have been waiting for an opportunity not only to do this major expansion of healthcare coverage, but to try to take a crack at doing some of what we call delivery system reforms and reforms in financing. So there's a lot of stuff in between the major provisions that are minor provisions that we'll go back to. But in addition, our healthcare system is confusing. So it's confusing for ordinary people. It's confusing for me when I try to go with my husband, who's a physician, and try to help him coordinate his medical care. And we get confused by what we're supposed to do, what's going to happen, what happens next, what do we do, what do they do. It's confusing. So it's not surprising that this 1/7, I think it is, of our economy, it's big. So it's confusing for that reason. It's also confusing because I got to tell you, I'm very proud of the fact that we got this bill passed. I'm a supporter.
This is a big step forward.
This is a big step forward.
And we'll talk about how.
Well, it's a big step forward. But it has been clear throughout the debate that there was a lot of misinformation, disinformation, and confusion. And we got this thing through really by the skin of our teeth, quite frankly. And what I'm really surprised about is that we haven't had a post-approval major communication campaign to actually clarify this for the American public.
Okay, before we get then to the law and health policy, let's talk about this health politics. The White House is awfully quiet. And given this widespread confusion, you would have thought it was prudent on their part to develop a communications campaign explaining the benefits of reform. They haven't done it.
Right.
Why?
Well, they're not stupid, okay?
No.
They're not stupid,
That's
they're not
the point.
ignorant.
Right.
They should know that they have to do this. So here's a couple of things that I think are going on. First, if they're going to do it right, they have to do it carefully. I'll
And
come
it
back
being
to
what? What is it?
the communications
Okay,
campaign.
go ahead.
They've got to figure out exactly who their audience is.
Okay.
They've got to target it not to everybody, but to the people who, A, are most confused, and B, likely to change their minds.
Okay.
Okay? There's a whole chunk of people, no matter what they say, they're going to hate this bill.
Right.
Okay? There's another group of people that they don't have to convince, that are already convinced.
Right.
It's that middle group.
Who are confused according to the Kaiser polls.
Right. They're definitely confused. They need to target them. They need to figure out what the framing and the messaging is for them. So that's one thing. And they don't want to do that instantaneously. But they should be on their way by this time. And second, you know what? They spent a year and more on healthcare and put a lot of other stuff on the back burner. And they got to pay attention to that other stuff now.
The economy, Afghanistan, the financial situation.
Yes, and financial, what they're debating in the Senate right now,
Right,
which
regulatory
is regulatory
reform. Sure.
reform in finance. They've got issues about, are they going to do immigration or are they not going to do immigration? What are they going to do with don't ask, don't tell? They got climate change. I mean, come on, these are really, and they haven't even paid any attention to the education piece, really, to speak of. So they got a lot of other agendas. And I worry, this is what I worry
Go
about,
ahead.
that they are in a place of saying, we've done it, it's done, we're on to other things. Because I don't think that's a good idea. And
So it ain't done.
it ain't done.
What ain't done? Are these reforms at risk?
Yes. And the major reason that they're at risk is because the big ticket item, which is the expansion of coverage to 30 to 36 million people, does not start happening until 2014.
So we've got 4 years to screw around
with it.
Okay.
And one of my peculiarities is that I studied many years ago the passage and repeal of something called the Medicare Catastrophic Coverage Act.
Go ahead.
Which was passed in 1988 and repealed in 1989 because of the same kinds of issues of miscommunication to the public, and people thought they were getting A, and they ended up thinking they were getting, Z, and they were not happy with Z.
Right.
And Congress wasn't happy because some provisions they didn't expect the cost increases that they expected. Part of it, this is a funny story, but we talk a lot about the Congressional Budget Office and how perfect they are. Well, they made a mistake. Right? They failed to cost out one piece of the bill. Naughty. And so what happened was that came on first. It started costing Medicare a fortune. And Dan Rostenkowski, this really tough old Chicago Paul, who was the head of the Ways and Means Committee at that point, I believe, he had all these Medicare beneficiaries stomping on his car in Chicago. This is not what
Chicago,
he likes.
come
It's
on,
Chicago.
come on.
Right, and he should have been willing, but he wasn't. And so that got repealed because there was a bad managing of communications.
So you
it
see
could
this as
happen
a
again.
precedent.
It could happen again.
So you have to be ever vigilant because
Yes.
even what's on the table right now can be taken off the table.
Absolutely, because we got an election coming up. Okay.
Huge election.
Huge election. After that election, a lot of people are saying that's what they want to do. They want to repeal the bill. And that could happen even with the support of the American people for the bill. And we really don't have clear support of the American people.
Right, which again is suggested in
for
the
the
Kaiser
bill.
polling. Right.
Now, here's what's funny.
Go.
We have not very much support of the bill as a big kahuna.
Right.
But for the major provisions
Right, all
of
the
the
little
bill,
pieces.
everybody likes.
Right.
So when you disaggregate it, people really like it. And they were very smart, I have to say.
Who's they?
The legislature and, the people who put this bill together.
Go ahead.
Because they did some things right up front that were going to be very popular. So one of the things that comes into effect on July 1st, I think, or maybe it's June 1st, is that there's going to be what's called a high-risk pool. So people who can't get insurance now because of a pre-existing condition are going to be able to get insurance.
Now that alone, I read 15 pages on that, and I'm totally confused.
Right, but don't worry about it.
Don't worry.
If
I'm not going to fall into the pool, I'm not worrying about it.
Right.
But for the purposes of the show, I want to know.
Well, what does that mean?
What does it mean?
What that means is that if you've been uninsured for 6 months,
Right.
which is a bit of a problem, and if you are not going to be able to buy health insurance on the open market
Right.
because of a pre-existing condition, you are going to be able to, and they're busily setting up this pool right now.
Right.
My buddies in DC are working, the 16-hour and 20-hour days that they have to in order to be able to get this thing in motion. And that's going to be a federal piece. That's got huge emotional positive stuff. I mean, what could you say about not denying
And this
people
is
insurance because they're
bipartisan,
sick?
bipartisan in some sense that the Republicans voted no.
Well,
totally.
they
how
can't vote.
bipartisan is it?
Look, if that never came to a vote separately,
Right.
I don't think the Republicans wanted it to come to a vote
'Cause some of
separately.
them may have had to
because
vote
some of
yes.
they would have had to vote yes. So part of it is, again, they had to put it together to get the vote through, but it's the disaggregation that's hard. So that's another one. Another one for anybody who has college-age kids, right, or kids in their 20s. Right away, kids up to 26 years old
Right.
can continue to be covered on their parents' health insurance coverage. And that's very big because there are a lot of kids, young people, who don't have insurance.
Okay, wait, you just mentioned two specific cases that could form the core of the communication strategy.
Absolutely.
Talk a little bit further. Let's concentrate on you're developing a communication strategy for the bill or the White House.
Okay.
Go ahead.
So accentuate the positive.
Right.
Right. We can't eliminate the negative, but we have to accentuate the positive.
And those are two of the elements.
Right. The other thing that I think is a tougher communication sell. So the first thing, let's go back to Communications
Go ahead.
101.
Go ahead.
What I talked about, identifying what your audience is. We have to do really in-depth, essentially, audience research to really figure out what the framing and the messaging is going to be. We're talking about positive messaging. That's all very well and good. The tougher issue is how do you counteract
the negative.
the negative advertising.
Right.
The death panels stuff is like insane.
Why don't you run it like a presidential campaign with immediate response teams? I mean, run it like a presidential campaign.
They brought David Plouffe back into the White House. And my hope is that the November elections is his job, and I hope that falling under that job, I don't know, I'm not there, is actually this task to create a communications campaign. They have the expertise. They know how to get the expertise. But I don't know why it's so slow. And
well,
maybe
you suggested attention.
Attention, but it may be that they think that they can wait on it until, for example, on June 1st, making a big brouhaha about the pre-existing condition thing. So I don't know what their plans are.
Okay.
But I think they could have been out there with some messages even now, because they've known that they were going to do this from August, right? When the death panel stuff came out. They knew that they should have known that even if they won, the battle wasn't, the war wasn't over. They'd won one battle, but the war wasn't over.
And the wars, in fact, could continue for
years.
The next half decade at least.
Absolutely. And so there's that. Now the piece that really is going to be hard is counteracting the negative stuff. And again, the audience is critical. For a group of people, they're going to believe the negative stuff, and nothing you say to them is going to change their minds. Okay, but what about those independents? Those independents that put Obama in office. Let's be clear about that. And who are very critical in this particular condition, because they're the ones whose votes in November are going to make the difference or not make the difference. So those folks have got to be appealed to. And the problem from my vantage point is, how do you say these people are lying? This is not true, because that's what's real. That this is not true. I think.
So you're saying there's a lot of lies out there.
Oh, yeah.
Purposeful misinformation.
Purposeful lies. I won't even call it misinformation. Let's put it what it is. It's lies, right? So the question is, if it's lies, we don't like to call people liars in this country, right? We don't do that. We don't say you're a liar, except, of course, if you're in a press conference with the president and you say you're a liar, right?
Score a couple of points. Go ahead.
Right. But it really is funny. But we've got to figure out, and one way to do it is to vilify the opposition, which is going to sound too partisan and too meanie, and Obama isn't a meanie and all that kind of stuff. So that means really countering by what is true, okay, and framing.
The truth shall make you free?
Well, no. The truth shall, I don't know what the truth is going to do.
Win out. You hope.
I hope. You know,
At least your truth.
but here's the deal.
Go ahead.
It isn't clear. The most important thing about this bill is that it's going to cover another 30 to 36 million people. And I'm not sure the American public cares about that.
What do they care about then? How do you hook them?
They care about, and this is somewhat cynical, they care about keeping their own coverage and having it not cost so much money. A lot of them also care about the overall costs of healthcare. And so a lot of people, including a lot of those independents, are disappointed because the bill doesn't really have a lot of really tough cost containment measures, right? The public
But
option,
you couldn't have tough cost containment issues because you would never gotten the bill because your organized opposition would have killed you.
Let's look back. The provision in the bill, the original kind of bill that was going to get you some cost containment was the public option.
Right.
And that got defeated.
Right.
Okay, in the battles. That got lost, that got given away.
Right.
Because basically people said, you know, it was almost like you know, a mother tiger presenting herself to the hunter in order to protect the cubs, right? So the public option was the lion, the tiger, and it's okay, you can kill me off, but leave my babies,
Okay.
right?
To mix the metaphor, the sacrificial lamb. Go
Right,
ahead.
okay.
Go ahead.
So here we have a situation where we really don't have much meat. We could never have gotten it. I mean, here's the deal about cost containment in health care in a nutshell. We spend 2008, $2.3 trillion on healthcare. Somebody gets that money. They want to keep getting that money. And anything that reduces costs is going to mean that they
get less
don't
money.
get less
I
money.
get it.
So it's very basic. And the other thing that I have come to conclude, looking at a lot of the international comparisons, is that the big difference between why we spend so much and why Europe or Canada spends so little,
Right.
they pay doctors and hospitals a lot less money for doing the same things. A lot less money. So I don't know how, you know, what you think, but I think that if my husband's neurologist was told that his revenue, his income was going to go down to European levels, he would be a very unhappy camper.
We get it. We get it.
So those solutions are very hard to come by that are effective and are politically, at this point,
So you
a
have
non-starter.
both a technical and a political feasibility.
issue.
Okay, okay.
But
Go.
people, but here's the thing.
Go.
People don't understand that. People don't understand why there isn't cost containment in the bill.
Okay.
All those people who are small business owners, big business owners who say, I'm getting it in the chin over here, paying for premiums. So they put a little bit of payment regulation into the bill,
Right.
which is hidden, but it's in there. And hopefully that will kick in. They've got a lot of demonstrations of how to reduce costs, and that could give us the technical side,
Right.
at least. But you know, quite frankly, Doug, I don't know how we're going to deal with this political side.
Okay.
When I was in graduate school, we were at about 10% of gross domestic product for healthcare. And my dear departed mentor said, if we get to 12%, there will be blood in the streets and a revolution and people won't think about it. We're over 16. And we're
it's
not
growing.
in revolt yet.
And it's growing.
So I think part of the problem is that there is very great distress about these costs with good reason. They're very bad for our country. But, you know, the reality is that turning this around is going to be 10 times harder than what we just did.
Okay. In the last several minutes, what does the new law do in outline form? And what doesn't it do?
Okay.
And what ought it to do? So we've got three questions. What does it do? What doesn't it do? And what it ought to do?
Okay. It covers a lot more people. It covers probably about 3/4 of the people who are uninsured. Of the remaining number, about a third of them are undocumented workers, and therefore people don't want to cover them anyway. That's a mistake, but that's how people are. So we've made a huge leap forward, but we are not all the way there. Okay.
Right.
So that's the first really big thing it
So
does.
it expands health
It expands
insurance
health
coverage.
insurance coverage.
Go ahead.
It also really does reform health insurance by a variety of ways. To me, one of the ones that we haven't talked about that I think is very nice, it's very sweet, is that the insurance companies they have to spend either, depending on the market they're in, either 80% or 85% of the money that they get in premiums on actual health care. Duh. Right.
Nice.
It's very nice because right now, with a lot of plans, what they spend is more like 65%, 70%,
And this goes
70%.
into administrative overhead?
It goes into administrative overhead. It goes big time into marketing.
Oh, right.
And then there's the P word. It goes into profit. Okay? These are not for-profit companies for the most part.
Okay.
So this could actually have a dampening effect on costs as well. We'll see.
Okay.
I'm not holding my breath.
What else?
What else? There are lots of so there's to go with the coverage are all these subsidies for people, which they have to have.
Okay.
And there are all these tax credits for employers, which they have to have.
So the main thing here is expanding coverage and in a minor way controlling healthcare costs. Is that?
Yeah, it's in there. And what there is in there too, over the last several years, policy wonks of various kinds, on the Hill, off the Hill, in the White House, off the White House, have known that there were certain things that we needed to do to improve our healthcare system. Right. Okay, a lot of those things are in this bill, were never discussed, were never debated, they have bipartisan support, and they're in there.
Okay.
Things like improving the transparency of the system.
Okay.
Okay. Things like demonstrations to improve the coordination of care. Things like help for people who need, who have long-term care needs and need some way to pay for, home-based long-term care services.
Okay.
I mean, these are big things. These are
right. Particularly as we get older.
As we get older, they're going to be big things.
Right.
There's nice pieces in there about reducing the donut hole in the Medicare prescription drug bill. Okay, so that's going to be very nice for older people.
What's the donut hole?
A donut hole?
Quick.
Quick, what it is. So, there is in the Medicare drug benefit, you get upfront coverage for a couple of $1,000s,
right? And
then the next couple of $1,000s
you pay.
That's the donut hole.
I get it.
And then you get back over the edge.
So you want to eliminate the donut hole.
We want to. It's gradually going to be eliminating the donut hole.
So you got three major consequences here, possibly: expand coverage, control healthcare costs, and improve the healthcare delivery system. It seems like on number three, that's less obvious and
no,
less
it's in
of a
the
goal.
fine print.
It's in the fine print.
It's in the fine print, but I have to tell you something. It isn't less of a goal for most people who have any concerns about health care. So there's a whole piece in there on public health and prevention that everybody wants to support. Very good stuff.
Good.
There's support for improvements in workforce and in things like coordinated care. There's a lot. There's measurement. There's support for improved measurement of health care
there's lots
quality.
of good stuff.
There's an enormous amount of good stuff.
But you're saying that a lot of this good stuff is vulnerable.
I actually think it's less vulnerable
because it's got
wider support.
Okay.
But the problem is, how do we communicate all this little stuff? Because we've got to take it from being a niche issue for people like me, right, to being an issue for the ordinary American citizen.
I get it. Okay.
And
what will the proposed changes, reforms, not do? What ought they do? What would they do, and what ought they do?
Well, starting with, for me, it would be great if the coverage expansion happens sooner. It's very clear that the only reason that it's happening later is the financing of this bill.
Right.
They couldn't get it to a financially feasible spot unless they waited until 2014.
They stretched it out. Go ahead.
But the other thing is there isn't a public option, and I think there needs to be at some point. And if this doesn't work, that's going to raise its head again, because the public option really creates a sort of a benchmark for how we really manage an insurance plan, and how we really reimburse providers.
Give me 30 to 45 seconds on the public option.
All right, let me just give you a thing the public option could do that would be very valuable. Okay.
Go.
Well, first of all, the public option could pay providers less. And that's one of the big issues. That's one of the things that that the insurance companies didn't like, because they didn't think they had the clout in the market to pay providers less. They'd like to, believe me, but they can't get away with it.
Okay.
So that's one thing. But there's another piece. Another problem with healthcare is that we pay the people who do the high-end, high-tech, expensive stuff. We pay them astronomical sums.
Right.
For my ordinary doctor who is trying to help me manage my diabetes, we pay really appallingly low numbers. That's primary care. 2% of the medical graduates want to go in there because they can't make any.
Because there's financial disincentives.
So we need to change the incentives and say we're going to pay more for primary care, which this bill does, and pay a lot less for this high-end stuff, which is overused anyway.
Okay, last 30 seconds. What can we expect over the next several months, and when should you come back to give an assessment of this?
Okay, I should come back in September. If this communication plan is not in the field in September, I'm going to start wearing black. You know, because it's, even though I'm a New Yorker and I don't always wear black, I'm going to be wearing black. So what we should be looking for are two things: actual implementation and rollout of some key provisions, and the development of a really effective communication campaign that has a big picture component for that big chunk of independence, and then some niche campaigns on some of the other issues.
We will see you in September.
Right.
Don't wear black.
Okay, I hope not.
My thanks to Shoshanna Sophia for easing my confused and troubled mind just for a little bit, and for shedding light and providing some insight into the U.S. healthcare system. Next week is baseball.
Yay.
One of my favorite sport reporters, chroniclers, Maury Allen, will be back to talk about his soon-to-be released book, Dixie Walker of the Dodgers, and a lot more. Join us. Hello, I'm Doug Musio. Let us know what you think about this show. You can reach us at CUNY.tv. When you get there, click on the bar that says Contact Us and send your email. Whatever it is. Thanks, no thanks, obnoxious, do it. Send it.